are super excited to have everyone tonight, especially our esteemed guests, Dr. Jason Dragoo and Dr. Ariana DeMers. We're grateful for them being here with us tonight to discuss some exciting advancements in the Apex Biologix Regenerative Medicine toolbox. Well, here's our panelists. Dr. Jason Dragoo is going to be going over the science behind protein concentrate and the outputs and efficiencies. And then Dr. Ariana DeMers is going to be covering the protein concentrate processing and then pricing between an a la carte variation versus packaging and what that does to the pricing structure. So again, we'd like to welcome Dr. Jason Dragoo, who is the professor and vice chair of academic affairs for the CU Department of Orthopedics and endowed chair of regenerative medicine. He has developed many procedures designed to augment the healing of a patient's own body. He is also the head team physician for the Denver Nuggets, as well as consultant physician for the U.S. ski team. Prior to this, he was the head team physician for the Stanford football program for 13 years. And Dr. Ariana DeMers is a board-certified, fellowship-trained orthopedic sports medicine surgeon. She is the past president of the Interventional Orthobiologics Foundation and is a sought-after educator and trainer in orthobiologics and ultrasound. She has successfully transitioned her rural practice away from commercial insurance to focus on holistic orthopedics. So again, we'd like to thank both Dr. DeMers and Dr. Dragoo for being here with us tonight. And at this time, Dr. Dragoo, we'd love to pass the time over to you and into your slides.
Well, thank you all. It's great to be here, and thanks for joining us, by the way. This is a great journey that you're going to see over time. And of course, this is a journey together that we're going to take, because what we, of course, value a lot at Apex is the collaboration with everyone using biologics and what we learn individually in our own practices and how we can share that with one another to come up with really the next generation of biologics going forward. And I have some exciting data to show you, because I think we've all heard about some really, quote, exciting things, and then it leaves us in the end with, okay, sounds great, show me the data. And so we don't want to do that at Apex, right? We want to get right to it and really have some proof about behind the products that we have and that we're generating going forward. A lot's happening, as you'll see, in the laboratory and the next generation of biologics, and some of which I want to show you here today. So at the last webinar, we talked a little bit about PRP and all the different forms and formulations of PRP. And then we talked a little bit about platelet-rich plasma. And many of us have been through the generation in biologics where this was the waste material, right? This was thrown out of the centrifuge collection. And then as we went forward and studied this a little bit more, particularly what started, I think, things off is the ability to form fibrin matrices to help us with cartilage transplantation and certain procedures, clotting, skin issues, and muscle regeneration, to be honest with you. So a lot has happened to kind of push platelet-poor plasma to the front line as far as biologics are concerned. So what then is then we wanted to know, okay, well, what's in platelet-poor plasma, and how can we get the most out of it, right? How can we have a little bit more customized biologics and to be able to form different products from the platelet-poor plasma? And so Apex has developed a new technology of fluid volume reducers. So it's a concentrating device, and this is a new generation of it, because what's available on the market now are the predicate devices have a pore size, as you can see here on the screen, of 65 kilodaltons. So that's kind of medium for trapping molecules and biologic parts of growth factors and proteins that we want. And so Apex was able to engineer a product with much less of a pore size, right? So then, as you can see, in comparison to the available market, that Apex has a 15 kilodalton. So this is a much smaller pore. And so then the aim of this sort of device is to trap smaller proteins and growth factors. So here's epidermal growth factor, and you see this is 6 kilodalton. So we wanted to do some science to see, can the filters capture small things like this? What about real beneficial things that we'll talk about tonight, such as platelet-derived growth factors? And you see with the previous filters on the market, this is too small to consistently be trapped within the filter system and concentrated. So again, there's potential with this new device. And so that is what we're going to talk about today is show me the data here on the apex filter versus the predicate. So this is how this study was done. So this took 12 human donors, and each of them had 120 cc's of blood that was drawn all at the same time. And then 60 mLs of this was used for testing the apex concentrator, and 60 was using the comparator from the marketplace. And then what this was analysis of kind of many things, including the whole blood, PRP from each of the donors, platelet-poor plasma, and then this platelet-poor plasma was concentrated, right? So then we also measured what was in the water or the waste product after the concentration, just to get a little bit of an understanding of the efficiency of the filter system. And so this is something, if you joined us on a previous webinar, this is what we talked about previously, was the difference between the current market filters and Apex. We talked a little bit about the pore size, right? The size of the filter, but this just describes a little bit that all blood from both were prepared in the same way, right? So the PRP was removed in the same way, centrifugation was in the same way. And then the end, what we came up with was that when the platelet-poor plasma was processed, there was differing amounts of final concentrate that were seen, right? So in the first column with the apex, in the end, that even though starting out with the same amount of plasma, 20 to 24 mLs of water were taken out, leaving a 4 ml final concentrate, which was more viscous, obviously, because more water was removed. That is in contrast to the market filters that were compared, where you see less water was taken out, and that then more of the concentrate was there. So there was higher amount of concentrate that was less concentrated, if that makes sense, right? Less of the water was taken out. And then with the initial analysis, we measured the platelets per the ml, and depends how you look on it, but the bottom line is there was more platelets in the apex device. Well, that was because it's more concentrated. You see, it's almost double concentrated. And so therefore it carried with it double the platelets. Here's what the data looks like. If you look at it from the laboratory, that again, overall amount of platelets are pretty much the same, but because there was the concentration of the apex device that was essentially double, then it was able to concentrate double the platelets. Now, some of you will say, well, that's actually kind of cool because we can capture some platelets even in the waste products of PRP, right? There is capturable platelets in the platelet-poor plasma. Others will say, well, I don't care because I'm not going for platelets in this fraction. Nonetheless, I think that this is a summary of how the filter systems work, how its efficiency and its ability to concentrate things. So whether or not you want platelets within the concentrate, this shows again the ability for the apex to really concentrate this plasma down. And so now to get to the heart of what we wanted to share with you tonight, which I think is really exciting, and that is the growth factors and proteins that we're trying to concentrate. We're trying to give more biologics, more power to the biologics we're giving our patients by concentrating beneficial against proteins and cytokines and factors. And the ones that from studying this from a long time, the ones that tend to stand out are the ones that I've highlighted here. And those are going to be the ones that I really want to highlight the data for you guys tonight, because for me, there's a good story to this, right? It makes biologic sense that if we can concentrate, let's just say A2M, which I'll talk about in a second, if we can concentrate that well, that is a beneficial uh, property, right? That gives us more anti-inflammatory, anti-enzymatic qualities to our biologic, and the list goes on. So the key to this is that we think that modern day filter systems can easily trap this A2M. And the reason is it's a really big molecule, right? So platelets are really big in comparison here, but A2M, in comparison to the other things we're looking at here, is huge. So it shouldn't be much of a chore for these filter systems to be able to concentrate A2M. And again, that has a biologic story to it that could be beneficial. But what about this next generation, right? What about below the red line? That's what might be able to be concentrated more with a smaller pore filter system, right? So then this is the 15 kilodalton system. This is Apex. So question is, can we trap more IL-1RA or tumor necrosis factor receptor, the soluble receptors, or platelet-derived growth factor? Is it possible? Because again, pore size is smaller, we can trap smaller molecules with this. And so that's the data I'm going to show you guys here today. So the first part of this story is A2M, right? Or alpha-2 macroglobulin. And as science goes on, we hear more and more about this molecule that's present in our serum and our plasma. And that's because it's a big molecule that works like this picture does, that it traps proteases and it really starts these proteinases, it traps them to decrease their potential abnormal or the inflammatory environment, and of course all of the negatives that proteases can have within our joints. And so this is a big trap. And so the more traps, the more of these enzymes that we could really put in this binding site so they are no longer active. And those of you who have used it in clinical practice have probably noted pretty consistent notes that I have, and that is that if we have a patient that has undergone surgery and undergone injections, and no matter what we do, we cannot control that effusion, and we give them an A2M concentrated injection, it has been the strongest thing that I have seen. And we'll hear from Ariana, but it has been the most powerful tool in those very hard to treat patients. So there is a definite clinical effect that we have seen with this. And of course, we're keeping track of our data. So that will be a subject of a future podcast, but it's no doubt that this works. And again, it's a large molecule. So then if we look at the filter systems, how does this do? So I want to bring you to the first graph here, right? And the first graph shows that where is all the A2M concentrated? Well, you see, it's not concentrated well in whole blood. PRP, there's almost none. And platelet-poor plasma, that's where this is, but it's not concentrated well because the platelet-poor plasma is a high volume, right? And so then both of the filter systems we see here did a pretty reasonable job of concentrating A2M. And so then that can have its own little, not little, biologic benefit of just concentrating A2M. If that's all these filters did, then this is actually pretty impressive, right? To be able to harness this from the platelet-poor plasma. And then if you look at this a little bit more between the two systems, and again, A is the apex and P is the predicate, you see that the A2M concentrates at about 1.1 times higher than the competing. And again, I think it's just a concentration value. It's just more concentrated, higher values of these beneficial proteins. And it's over 5 times more than found in PRP, right? So overall, the filter systems did a similar job with regards to the collection of A2M, and it is one of the principal beneficial things that can be concentrated, or biologic components within the platelet-poor plasma. Yes, Apex did more concentration, and I think you'll just see that consistently through the numbers as we go on. The second thing that I think that we've all heard about is IL-1 receptor antagonist, right? Or IL-1RA. And those of you who are not familiar with it, we have the activated macrophages, right? And with those can be inflammatory, and they can then put out one of the main inflammatory mediators, which is interleukin-1. And when that then is at the cell surface, integrated into a cell surface receptor, it activates inflammation and a set of pretty complex processes within the cell. But if there is interleukin-1 receptor antagonist, this antagonist can fill the receptor site of the receptor, but you see if it does, it will quench it, and then there will be no activation of the inflammation. So it's a neutralizer, right? The more IL-1RA, the more receptors that are satiated, and the less of IL-1 that can activate cells if it's present in solution. So we care about this, right? Because we care about neutralizing and preventing inflammation, but we also care about how much IL-1 is there versus the ratio of how much antagonist is there. And this has been studied really well in the veterinary literature. And I think it's pretty well accepted that there needs to be a ratio of around 100 to 1, or 100 components of the receptor antagonist floating around to every one of the IL-1 molecules, right? We need to flood the market and quench the system. So that's why it's not only important when we measure in science that we measure IL-1RA, it's not good enough. We need to measure the ratio of IL-1RA to IL-1. Okay, I'll explain that a little more if anyone wants in the future. But so then let's look at the data here, between the systems. And the first thing is, if you look at here, the mean amounts of IL-1 concentration, again, Apex concentrated better than the predicate device. So that was clear, statistically significant, as you see here on the graph. Obviously, there's more IL-1RA compared to just floating in plasma. It's not concentrated. It's too high of a volume. So it's not efficient to inject. So therefore, again, increasing in the filters compared to platelet-poor plasma, with Apex being significantly better than the comparators. But I think equally important is when you look at the absolute value of this compared to, here's the sister graph, right? And this is the sister graph of the patients and their amount of interleukin-1 beta, right? And what we see from this is that Apex ratio of the IL-1RA to IL-1 was 100 to 1, right? That's that threshold to be significant, right? So then keeping track of all this, we have a plasma concentration device that is already concentrating A2M, which is anti-inflammatory. But now we have a clinical effective dose of IL-1RA in these patients, in these 12 donors here. That's benefit number 2 of the platelet-poor plasma concentration device. So again, this is the second beneficial thing, and I think that's why I'm excited about it, right? Here's the science that's showing that there is actual benefit of this. But part of the reason I'm so excited is because it doesn't stop here. This story just keeps on going. So I'm going to keep going and show you the data because if I were to ask you all, well, what's the other big inflammatory mediator that we deal with in our joints and soft tissues? TNF, right? Tumor necrosis factor. And it's interesting, TNF is really complicated from a molecular standpoint, and its regulation is really complicated as well. So to control this in the body, the body has soluble receptors. And this is a little harder to explain, but if TNF docks on a surface receptor, then it's going to activate this inflammatory response within the cell. So the body has these soluble receptors, which means that they're not docked to the membrane of the cell. They're kind of floating around, as you see in this cartoon. And so you can kind of think of these soluble receptors as gobbling up free TNF that's just floating around. And of course, TNF has high affinities to these soluble receptors. So the more receptors, the more TNF gets taken off the market before it can dock onto the cell surface receptor, right? Hope that makes sense, but it's the kind of the Pac-Man to get rid of this. So again, this is kind of similar story, isn't it? That we have autoregulation in our body of these inflammatory mediators, and we have things within our blood and within our plasma that can counteract the inflammatory response. And so again, we need this ratio, right, of the TNF receptor, soluble receptor antagonists and TNF. And so then here's what we have. I have two graphs here, but again, both showing that the concentration of these soluble receptors is much higher in the apex in comparison to the predicate device. And of course, much more than in PRP, right? So that's what this first graph is. This first graph is the filter concentration versus PRP. And you see wildly, much more of these soluble receptors. But then you may be asking, well, okay, well, how come Apex then perform better than the predicate? And the answer is the pore size, right? We're getting down to soluble receptors of 26, right? So those big other the predicates, they have too big of pores. So they don't do as good of job as collecting this. And so it's again, one of the benefits of a better technology of filter system, because it can trap more of these small molecules. And these small molecules are ones that are really important as far as controlling inflammatory environment. The next graph is platelet-poor plasma, right? So there's more of these soluble receptors in plasma. We were just talking about that. But again, can you concentrate these small molecules within plasma? And the answer is yes. But look, that the apex concentrates much more because of its small pore size. And you see very little concentration of these soluble receptors, right, compared to just platelet-poor plasma with the current marketplace ones. And again, it is just, I think, a factor of the pore size, statistically significant results. And so then, see, this is actually a really cool biologic story we're putting together. So again, reviewing, we got A2M, right, that can help us with enzymatic control. We have IO1RA that statistically increased within the concentrate, and now we have soluble receptors of TNF, right? So we're on a roll. This is actually really exciting of concentrating biologics that obviously haven't been done. Well, let's keep going, right? Because this is a lot of fun, and there's so much to this story, and this is actually one of my favorite stories. And this was first, I don't know, this was popularized by one of the labs of Arnie Kaplan, who we all know passed away over a year ago now. And when we were talking, and he shared with me this really novel finding, right? And that is when they looked at these MSCs, or let's call them more appropriately here, parasites, which are MSC-like cells that naturally are on our peripheral vascular cells, right, in the edges of arterial here. Then the question was, well, how do they know when to, when to release? And what they found in their studies, what is this platelet-derived growth factor, and it was the isofraction BB, right? So it comes in three forms. AA didn't do it, AB didn't do it, and BB did it with much higher efficiency. So then the question is, can we trap this? Because if this is concentratable, then we can help release local cells within the environment that we're treating. So it's kind of this bridge between cell medicine, previously known as stem cell, right? And these progenitor cells, we can increase the local tissue level of these cells, release them off their vasculature if we can trap platelet-derived growth factor. Well, this has been a problem before, and the reason is because it's difficult to concentrate. Why? Because it's small, right? So this isn't 25 kilodaltons. So this is a little different story here. And this is a little different in a lot of different ways, yet very biologically important. And so I want to show you that here's this data, and this data is interesting. It takes a little time to sort through. But the bottom line is this: platelet-derived growth factor. This is mostly found in PRP segment, but that when you centrifuge it out, most of this is collected and released with platelet lysis. So this is going to be found within the PRP fraction with a much higher amount than the platelet-poor plasma. Okay, so I just want to say that it makes sense, platelet derived, right? It's from the alpha granules, so it makes sense that this is where we're going to find the platelet-derived growth factors. Okay, but then the question is, well, can we also increase this biologic, which could be beneficial for, again, the release of the parasites from this portion of the platelet-poor plasma? And the answer is yes, right? And Apex does it 2 times more. Why? Pore size. It's 25 kilodaltons, right? These are really small. So we need a really small filter size to be able, pore size to be able to do this. So um, there's no doubt, right, that Apex perform better just because it's a different filter size, right, than the other. So then that's clear. But it is clear also that this was concentratable from platelet-poor plasma. So again, if you look at this, 200 picograms, all right, that's a lot, but look what we have in PRP, right? We have the nanograms, we have a lot more here. And so then with that, our next project with Apex Biologix is taking this small filter size and concentrating our PRP with it, right? Because if you really want really high quantities of platelet-derived growth factor, we need to go to the PRP fraction. And then if we can capture all of that in a very concentrated way, we're going to have it's going to be a great thing, right? That's talk about statistics and blowing something out of the water. We can have very individualized biologics, that protocols that can maximize the production of platelet-derived growth factor, BB. And so I think this is, again, super excited. I'm super excited about it. Whether or not you just want to concentrate platelet-poor plasma, you get another benefit of the biologic there, or whether or not you want to go for the 5-star, right, platelet-derived growth factor bonanza by concentrating PRP. That will be a subject of a future webinar, right? We'll then release how much we can get. But the summary is this is really cool. Being able to concentrate these biologics in this way and going forward and getting new iterations about how we can improve already on what we have here today. Well, this last one from a biologist, and again, happy to take any comments, on this one, epidermal growth factor, and from biology, I don't really know the connection of how you would use this in orthobiologics. I mean, maybe in skin and skin disorders and folks in plastics and other ones, that this may be a really beneficial thing. I'm obviously from the orthopedic side of the fence. And so for me, I don't know how to put this in the biologic equation. So, but we have some data on it. And I think the thing that is most important to me is the fact that that this can be concentrated because this is one of the smallest proteins that are around 6 kilodaltons, right? This is really small. And so I think for me, this shows that the filter works with really small molecules. Those of you out there that know in your specialty that epidermal growth factor is good in the way that you want to concentrate it, awesome, right? Because here's the data. And the data shows, again, because of the small pore size, that compared to the predicate, the apex did much better. Compared to platelet-poor plasma, it did much better. This is another one in the PRP fraction. So those of you, again, who want to optimize this for personalized biologics, then we're going to be able to concentrate this much more from the PRP fraction of this. Sorry, did somebody want to make a comment? I can't see, but did somebody comment?
You're okay, Dr. Dragoo. Dr. Bert Mandelbaum actually has joined in with us, so we're excited to welcome him to the webinar. So that
Oh,
was him.
great. Hey, buddy.
Hey there, Jason. Good to be here.
Yeah, well, thanks for joining us. And we were just going through the data. This is actually kind of getting towards the end of it. But again, just really noting that this is a filter efficiency thing for me. I wanted proof, right, that this filter stood up to the data and is delivering high charge biologics. And I think this data is showing that, right? And it's behaving in the way that we thought from a molecular trapping scenario. This also was really important to me, right? Because then it's like, okay, well, filters are taking some stuff off the top, but I really wanted to know, well, and I think Ariana is going to show us this, but you put in your platelet-poor plasma, you put it through the filter, and then you get your concentrate, right? But you also get a lot of wastewater, right? That's being filtered out, and that's concentrating things. So my question was, all right, you're getting all this water. What's in the water? Are these filters good? And so there should be nothing but water in the water? Or are we missing stuff because the filters aren't that good? And so therefore, yeah, we're concentrating things, but only to a certain level. Well, check out this data, right? So one of the things that we talked about from a biologic perspective is these anti-TNF molecules, right? These soluble receptors. If the water's the water, this graph is a 0. And with the apex filters, no soluble TNF got through the system and into the water. But because of the small size, again, of the TNF, you see that lots of TNF got through the filters of the current marketplace, right? So then this is a lot of wasted anti-inflammatory capacity because the filters just aren't to the newest level of technology, so they can't trap it, right? They're too big to do it. And so that is a big understanding for me of the efficiency of the 15 kilodalton filters. Now, IL-1R array, we talked about that, and we talked about, well, that's actually really important as well. And neither achieved 0. But again, look at the difference, right? That there was some IL-1RA increasingly got through the filters of the current marketplace and not of the apex. So again, I think it's really just showing the filter efficiency of this new small pore sized filters, which is the next generation of the protein concentrate filters. So this is my last slide, and then I'll turn it over to Ariana. But I just wanted to kind of give a slide just to summarize things. And so I highlighted a couple of columns. And again, here's all the numbers that we're talking about. And here is the apex in the gold. And here is the comparable concentration device predicate on the market. And if you go through side to side, you see that essentially the apex did better, right, in each of the columns. And again, this is an independent laboratory. This was not done by Apex. And I failed to mention that, but that's the truth of this whole thing. We see the fold concentration that the the Apex device was able to concentrate each of these beneficial biologics in comparison to platelet-poor plasma. And then just for, again, showing how it compared in comparison, Apex in comparison to the comparators. So again, numbers say a lot, right, of this, and statistical significance says a lot, too. But I think the bigger thing is we are able to concentrate biologics here in the previous waste product of biologics, the platelet-poor plasma. These filter systems are available now, and I think Ariana's going to go over it. But what I want to say is that this is just the beginning. Like, yeah, we have these now and we can use them, and great. And we're going to continue to build, and we're going to continue to build customized biological systems that, as you guys as physicians and healthcare practitioners, and you want to deliver a custom biologic because you, as the decision maker, feel that they need a certain thing for their particular disorder, that's what Apex wants to deliver in the future. So we have it now. We're going to have even better things in the future. But I thought this was really exciting news that I wanted to share with you all. And I hope there's some time at the end for some interaction between everyone here. But I'm going to stop sharing my screen and give the floor to Ariana to take it over from here.
Wow, that was fantastic. What an enormous brain dump of all of the science and biology that we've been talking about for quite some time. And this is kind of a culmination of things that we've been wondering about for a while. And so this is super exciting. Thanks so much for making a complex topic really clear and straightforward. So that was great. Thanks so much. I am going to talk a little bit. I'm going to show a little bit about what we are talking about. I'm going to share my screen right now. And then what we'll be talking about is that we will just go ahead and give you a quick rundown, but also some pricing strategies, because this is a question I get all the time is, how do you charge for this? What do you do for this? What's going on? So obviously this is me, and I'm going to go ahead and just play this little video. And this is our device. So for all of you who have not seen this device, this is where we're going to go ahead and attach our filter to the device. And then these little 90-degree stopcocks have been the second generation. This is a really important improvement to be able to push all of this fluid through this filter. This is that PPP that we used to just throw away. And now we have heard from Jason that this is super important. So we're going to go ahead and attach that, making sure that the flow is that 90-degree flow. And this is a pre-wetted filter, but we do need to purge the air out of the system. So that's what we're doing here. You go ahead and just push that PPP up until you get resistance, and then close that air purging valve off. And then go ahead and take that blue cap, attach another 60 cc syringe so that we now can kind of push that PP across that filter and be able to connect both of those stopcocks so that we have flow back and forth through the syringes. We'll make sure these are adjustable because we do want to have the same angle on both of the syringes, because we're going to be using the tabletop to be able to pass this back and forth instead of using your thumbs and really getting thumb fatigue, if you will, because it becomes quite thick. Then we're going to go ahead and take that white cap off and attach our vac lock syringe. This is going to be that negative pressure that we are then going to be able to draw that water out of the system through that 15 kilodalton filter, and then just pull that to activate that system. That's going to be quite difficult. You just got to give it a good, a good pull and then lock it. So that's going to keep that negative pressure. And then that's where that water collects. And then we're just going to go back and forth using the power of the arm. You're going to see back and forth, and you can see that water efficiently being filtered out through the filter. And this is our obviously, fast forward. The lab is going to take a little bit of time to do that, but we go ahead and push that through all the way until it is completely flush into the filter. And look at all that water that's taken out. We're going to take that vac lock syringe off and secure the cap. And then we'll go ahead and collect our platelet concentrator, plasma protein concentrate. Obviously, we have to draw the air in to be able to collect that protein concentrate on the other side. And that has been reproducibly the 4 cc's. Once you get the air bubbles, go ahead and just stop pulling. There's nothing left. And that's that 4 cc, very viscous fluid of the protein concentrate. And this is the liquid gold that we're talking about today with the nice thick viscous concentration. All right, so now we're going to move on and talk a little bit about pricing. This is the question that I always get, like, how do you know how to what do you charge? Do you charge separately? Do you charge extra for this protein concentrator? Do you use the protein concentrator only? Do you use platelet-rich plasma only? And so really, please don't rely on your competition to set your prices. Please do your own research on the value that you're providing for your patients. This is a new technology. This is not available from every widget out there. So this is important to know. So I want you to understand a little bit about the pricing strategies and just understand that there's either a la carte or package pricing. So a la carte is where you just charge for each piece of the service or treatment. This is common in your fee-for-service models. And then the package pricing is, I think, a little bit harder to wrap people's brain around, but I'm going to ask you to suspend disbelief for a little bit. And I'm going to prove to you that this bundled pricing for a combination of services or treatments may be often used to offer more value and convenience. So considerations, if you're talking about a la carte pricing, you do have transparency in our pricing. Everyone knows which piece is what costs and what they're paying for. It does allow for that flexibility for patients to choose their specific services, and it's a little bit easier to manage and adjust pricing. The cons are that it may end up being more expensive for the patient who's needing multiple services. And this leads to lower perception of value. And on the back end, may be more complex in the billing process. Why package pricing makes sense is because it provides clear value, and it may also provide cost savings for the patients. It simplifies that decision-making process for the patient, and it's just a yes or a no instead of picking from a menu. And it encourages the use of a comprehensive treatment plan. Obviously, there's some less transparency in the pricing, and it may discourage patients from using a single service, but I think that if you stick with me, you may see why this makes sense. Obviously, we have to always make the right decision for our patients. We've got to look at our patient demographics, maybe take a look at our marketing competition pricing strategies, but really please don't base your pricing strategies on the market and on your competition. Please base this more on what you can provide from a value perspective for your patients. And I am going to draw you to this purchasing behavior. We've all had that experience where we've been nickel and dimed, and you think the price is one thing, and then they're like, oh yeah, this add-on fee and this other fee and this other, if you want to check a bag, you're going to have to pay more. And if you want the window seat, you're going to have to pay more. And then when it's all said and done, you could have actually chosen the more expensive flight that was all included, 2 free bags, window seat, no problem. And so I really, when you're purchasing, that psychology of all inclusive versus nickel and diming, I'm going to encourage you to consider package pricing. So I'm going to give you 2 examples of package pricing. These are real world values. This is a knee joint platelet-rich plasma plus PC. This is $2,500. And then if you wanted to add laser, you can add that for $9.99. You can add 3 months supply for arthritis supplements for $4.79. If you wanted some CBD for the after injection soreness and inflammation, that's $99. Maybe add a bio brace, that's $79. And you get a whole cost, whole total for the patient of $41.57. If you look at the cost of goods only, that's about $1,300. And so you net about $2,857, maybe, if they wanted all of those goods. Or maybe it's just $2,500 and we minus the cost of goods at $450 and say we have a net of $2,050 for an injection that you charge. Now, this is where we talk about package pricing, and this is real. This is a knee joint platelet-rich plasma plus PC. This is not differentiated. It's PRP, PC, it's all included. Whether you need the PRP, the PC, one or the other, it's all included. This also includes pre-injection nutrition optimization, laser therapy, CBD, BioBrace. Total is $3,500. Cost of goods, $1,100. Net, $2,400 every time. And there's no negotiations. There's no picksy-choosies. Oh, I want this. I don't want this. This is more of a gym membership where it's all available to you. You choose if you want, if it's right for you, if you're looking to get strong or you're looking for toning or you're looking for, your cardiovascular workout. And this it allows us to optimize our outcomes without regard for price because it's all included. So my recommendations for platelet-rich plasma with the plasma concentrator is to bundle that in because we have such an opportunity to improve outcomes. If patients are then seeing that increased cost, they may choose to go without something that may optimize their outcomes. So ultimately, package pricing for the win every time for me, but please consider that this may also give your patients less decision fatigue and improve the value and optimization of the outcomes. And if you have any other questions about the business of orthobiologics, please subscribe to my podcast, wherever you get your podcasts. And I thank you so much for your undivided attention. I'm going to stop sharing it and we're going to go to our panel. So I am so excited to kind of dig in to any questions. Hopefully that wasn't too breakneck pace, but I wanted to give us time to answer any questions from our attendees, please.
Thanks, Dr. DeMers. Thanks, Dr. Dragoo. So we do have a handful of questions that have come in, and we have about 5 minutes. So I am going to read a few of them to you, and we will get through as many as we can. One of the first ones was, when would you choose to inject PRP plus the concentrated platelet-poor plasma versus just the concentrated platelet-poor plasma in isolation?
Yeah, Jason, I get this question a lot. What's your thoughts on this?
Yeah, I'm sorry. Is it PRP versus the protein concentrator, or protein concentrator versus platelet-poor plasma, just unconcentrated?
No,
Yeah.
so PRP plus PC versus PC alone.
Oh, so a couple of things. Number one, as And there's a sister question coming out there. Haven't seen a lot of data, right? And published articles. And, in Europe, there is actually a lot on IO1RA where they actually have products that are available there. In the veterinary literature, there's a lot on it as well. A2M is less. I mean, what you see is the science articles and let's just say anecdotal reports, but you're right, there's not a whole lot of published articles. However, what I think the modern day biologics clinics are doing, like ours, is gathering a whole lot of data now. So there's going to be another data dump coming, which has to do with how A2M concentrating devices do. And when I have a troubled patient where they have, again, as I'm explaining, where there is a refractory effusion, inflammation is their key thing, I am using the protein concentrator, right? Because that's where we're getting the A2M. That's where I've had the best results. It's anecdotal. We're studying it, but at this time it's anecdotal. PRP has to do with a lot of other things, right? And the benefit of the level 1 evidence used in osteoarthritis. And so obviously with complementing rotator cuff repairs also is another thing. So then those are the ones where it's not this osteoarthritis with a bunch of an inflammatory component. This is just a little bit of reactive knees, a little bit of stiffness in the morning, that sort of thing, injecting just the PRP and not the concentrating device. How about you, Ariana? What's been your experience?
Yeah. So I started out just using the protein concentrate for these inflammatory things like adhesive capsulitis. So anywhere I would use it anywhere that we would typically use cortisone. I am now using that plasma concentrate just because we know that there are such powerful anti-inflammatory modulators, and then we don't have the detriment of that cortisone as well. When we look at this most recent data, though, adding platelet-rich plasma with the high concentrations of the anti-inflammatory effects as well, I think it's really I'm being pushed more to do platelet-rich plasma plus protein concentrate in a majority of the things. I think you're right. There is one application, that rotator cuff, like an intratendinous rotator cuff injection of PRP. I'm not going to use the protein concentrator for that because I kind of do want that inflammatory the effect, and I don't want to quash that as much.
I see
All
another
right.
question about how is this protein concentrator different than just using high platelet counts, right? And it's a great question, right? Because we have some preliminary data. I think it's also going to be a subject at a future webinar, but it is, what is the optimal platelet concentration? Are more platelets better? I think there's some preliminary evidence to suggest that higher platelets have more of a response of patients, especially in knee osteoarthritis. But as we talked about in the basic science section of today, some of the things, including A2M, live in the platelet-poor plasma fraction. And so that is the difference between just concentrating to 10 billion platelets. You're still not going to get the things that are captured within the platelet-poor plasma. And so that's the difference. Now, certain things such as the platelet-derived growth factor, those are in the PRP, so concentrating PRP into higher concentrations, smaller injectable amounts may be beneficial, but certainly there's some things. A2M is a good example of that, and the again soluble receptors, IO1RA that are IO1RAs in both the PRP and the platelet-poor plasma, but the soluble receptors in the platelet-poor plasma. So there are things to be beneficial that are things that can be beneficially concentrated in the plasma that are different than the PRP. And I think that would be the best way to look at that.
I agree. I agree. I do see that there's one question about how much blood are you generally drawing, and then how much PPP is being pushed through the filter. So that's a minimum of 60 cc blood draw. I am rarely drawing limited just 60 cc's, just because of the nature of what I'm treating. I'm usually treating both intra-articular and extra-articular structures, and so I'm usually drawing 120 cc's. And so can you push 100, that 60 cc's fraction of PPP through the filter? And the answer is yes. So we've tested that out thoroughly, but you can concentrate it to about 8 cc's, or 8 mLs, which is, when you looked at that study, it was 60 cc's of blood for basically 30 cc's of platelet-poor plasma for the study. But I make a double batch for my patients, and you can push that through the filter. It doesn't clog or anything like that. I think, let's see here. I see, are you using this concentrated PPP in joints and soft tissues? I think we answered that. It's majority joints, less so on the soft tissue applications, but I do use it for that adhesive capsulitis, shoulder adhesive capsulitis. I use that a lot.
Yeah, and can I also, something that's going to hit the literature here pretty soon is the data surrounding the use of platelet-poor plasma in muscle injuries. So stay tuned for that. I don't want to say too much, but it's pretty cool. We use it a lot. And again, it's in our professional athletes anecdotally because of how they heal. I want to not say much until we get data. But lots of basic science data to suggest that the use of platelet-poor plasma in muscle injuries is advantageous to avoid scarring and to promote muscle plane regeneration. So again, we'll show you the data coming up, but that's the other place where the use of platelet-poor plasma is increasing during the past couple of years.
Yeah, absolutely. Now, Jason, are you using that concentrated platelet-poor plasma, or are you using that dilute at higher volumes for your muscle injuries?
Well, I've just been using regular platelet-poor plasma because I just haven't studied it, and we're doing studies, like I said, so I can't switch right in the middle of a study and using the concentrator. So I don't know the answer to that. I'm using just platelet-poor plasma in small volumes. And certainly doing some hydrodissection in the fascial, the area where the fascia could be, muscle fascia could be scarred, but small volume injections with just regular platelet-poor plasma. And again, yes, we're going to do more studies in the future with platelet concentrate. I just haven't done those studies, so I can't comment on it.
Sure. Okay, great. Let's see here. We've got a couple others. When doing intraosseous injection, would you also inject the PC with the PRP? I think, intraosseous injections of PRP is a little tricky. I think the viscosity is going to be really hard to inject intraosseous. I'm not sure that it will actually go. I have not put the protein concentrate intraosseous for that exact reason, because it's quite viscous. I think it'll go through a 23 gauge. That's risky. 21 gauge or higher. If you need to push it through a 25 gauge, I'm going to recommend that you dilute it with your platelet rich plasma. Otherwise, it's not going to go through a 25 gauge needle for sure. Let's see here. Last little bit. I want to be respectful of everybody's time. Can you use the PC on bone marrow? I have not tried filtering either PRP or bone marrow concentrate through this filter, but what I have done is that platelet-rich plasma fraction of bone marrow concentrate, we do push through the filter. All right. I don't see any other There's one, have you had success in gout in intra-articular injections with PC or PRP? I don't think that's been studied or looked at enough to really weigh in either way. So I personally have not used that, and I think it would make me a little nervous just because I don't have any data for me to stand on yet.
It's interesting though, right? Because it's very
Yeah.
inflammatory, right? And the gout
Mhm.
process, the crystalline process, is an inflammatory process. Whoever plays that question is insightful, right? It's not been standard practice, obviously, to give injections in that. And then maybe as we go on, maybe we start reflecting, why haven't we? And I think that there's a
Yeah.
lot of change of practice that can be, and especially when we do understand from the beginning of the anti-inflammatory capacity of something, then, let's do some trials together, right? Let's collect information together. And that's one of the things, I don't know if Bert is here, but we're all part of this biorepository network where we're keeping track of what we do so we can all learn together. And again, I would encourage you all to think about collecting all of your results and all of these great ideas that you have, and making sure that you keep track of your patients and how they do, and we can all learn from each other going forward. So Josh, I think
Great.
is at the end of our time.
Yes, that's it. We have a few more questions filtering in, but what we'll do is we will compile those and work with both you, Dr. Dragoo and Dr. DeMers, to kind of do a recap and get those out so we can answer the questions that are being asked. Again, thank you both so much for being here and for sharing with us your insights and the data that we've been able to receive to this point. And then setting it up for future webinars that are going to be, very data based. And we're so excited to be able to bring this in and to have both of you and Dr. Bert Mandelbaum working on this to provide this information for everyone. So thank you again, Dr. DeMers and Dr. Dragoo, and thank you for all those that attended tonight and for joining us on today's Liquid Gold webinar. We hope you found it was very insightful and the information valuable. Again, thank you all and have a good night.
Thank you all.